short for cognitive behavioural therapy, currently, as it stands in the UK, but also worldwide, is probably one of the most evidence-based therapies for a whole variety of depression and anxiety disorders. So it's the most widely used. In terms of what it is, CBT tends to focus on the here and now. It looks at what are the current difficulties and areas of distress that someone is experiencing. And the way that we look at those areas of difficulties and make sense of them is by trying to break down problems or areas of distress into thoughts, feelings, behaviors, and physical sensations. And in doing so, what we are trying to understand are what are the thoughts, which is your cognitive bit, and what are the behaviors, which is your behavior bit of CBT, that are maintaining an individual's distress or their problems.
Hi, Harriet. Welcome to the Never Fully Heard podcast. Thank you for coming on.
Thanks for having me.
Yeah, good to see you. Where I want to start is just to give some help set the conversation up. Do you mind just giving a quick run through of your professional background to date?
Yeah, so I'm a qualified chartered clinical psychologist currently, but the journey to get here, I guess, was to study psychology at A level and then undergrad, and then to work as an assistant psychologist and in part also as a graduate mental health worker in the NHS. And then from there, I trained as a CBT therapist, which involved doing a year diploma, and then went on to do a 3-year doctorate in clinical psychology. So I suppose if you equate it all, it's 7 years plus of education, which has led to me being professionally where I am now. It's also involved a lot of experience because with both my CBT training and my clinical psychology training, a bit like medics, we are required to kind of be on placement 3 days a week, seeing clients and actually kind of practicing what we're learning and being closely supervised and evaluated through that process. So that's a bit about in terms of my training. In terms of my experience in mental health, I started working with more kind of common mental health difficulties. So your kind of more everyday low mood and anxiety disorders that the majority of the population will experience at some stage in their lifetime. And slowly, as the years have gone by, I've specialised a little bit more, initially in trauma and PTSD. More recently, I'm working with people who experience psychosis in addition to trauma and PTSD, which is where I am now.
Thank you for sharing. I mean, an incredible amount of, I guess, education and investment in the learning process so far. How do you have to have a certain amount of hours of supervised time to be is that an element of it?
Yeah, so to be a clinical psychologist or a cognitive behavioural therapist, part of the training requires that you have a certain amount of hours practice, a certain amount of hours actually in supervision, as well as a certain amount of hours teaching. And that varies depending on whether it be the CBT course, which, as I said, was a year, or the clinical psychology doctorate, which is 3 years and requires also a thesis and to do a viva, much like you would if you were doing a PhD at the end of it. So yeah, it does depend on the training program, but absolutely there's a rigid minimum criteria for CBT training set out by the BABCP, which is the British Association of Cognitive Psychotherapy, and or the BPS, which is British Psychological Society.
Amazing, thank you. And considering that it's a huge kind of investment and time of your life that you've spent dedicated to this space, what led you into the space, and what was your motivation behind starting your journey into this space?
It's really difficult to pinpoint what came first because I know exactly the period of my life when it was. It was when I was roughly 14, 15. I developed an interest in talking more in a kind of sort of counselor-y type way. But I also, around that time, kind of got wind of the fact that we could do psychology A level at the school I was at. And I'm not quite sure what came first. And what had preceded this was a period of kind of feeling quite lost myself as a 14-year-old teenager. So there were a few kind of events that happened in a year or two around the age of 14, bearing in mind I was a female adolescent in my prime of hormonal kind of upheaval. And it's really difficult to know what came first. But one of the things that I very clearly remember is that at school, I was the go-to person quite often when someone was upset about something or they'd had a fallout with a friend. I was quite often that person that I think people thought that I could bring like a rational, quite balanced perspective to situations. So I can remember as early as that kind of having a love of talking and listening and wanting to help, which I guess is the foundation of ultimately what I still do now. And then I was lucky enough to be able to do psychology A level at school. And actually, this isn't a poor me thing, but I'd always been kind of middle of the road at school. Didn't really excel in anything, liked sport, but wasn't in the A teams. Crap at drama, couldn't sing for my life. And suddenly I did psychology A level. Not only did I really, really love it, but I was actually really good at it. And it kind of like married up with this love of talking to people and wanting to help people. And then, oh my gosh, I can actually get the grades in something for once. So it was a really, really sort of lovely combination of circumstances that then grabbed my interest and kind of incentivized me to then go and want to learn more, which is what I then did. I'm studying at Leeds, doing an undergrad psychology, and then it just kind of went from there. All of those same principles of wanting to help and feeling like I could really do that, and I was genuinely passionate and interested, and also quite good in terms of the academic side of things at that stage. Kind of propelled me onto the next stage, and it just went from there, really. That makes it sound like it was a really smooth and easy choice, and I've never taken for granted that from quite a young age I've always known what I wanted to do as a career. That said, there's been a lot of bumps in the road, because whilst it was quite smooth going from transitioning from A level to university, actually getting on a doctorate course to do clinical psychology is highly, highly competitive in the UK, not least because we're lucky enough that it's funded by the NHS, and you don't just have your university fees funded, but you're also on a salary during the 3-year training. So that attracts even more interest from people, understandably, because otherwise it would be unfeasible for a lot of people. But what that involved for me and what that looked like was 5 years of rejections, of trying to get onto a course and not getting on, and having to plug away as an assistant for yet another year, not really knowing if all this hard work
Wow.
was ever going to come to anything. And of course, in the blink of an eye, suddenly all the kind of ducks were aligned, and it did. And I'm very grateful for my qualification now and that I'd stuck at it. But there were lots of years of self-doubt and actually kind of wondering whether it was really worth persevering or whether I needed to change tact.
Yeah, that is an amazing story of perseverance, and also like I can hear the passion in your voice. That it was clearly the combination of finding something that you were good at and that you had a real interest in. I think it's quite rare, to be honest, from knowing friends and family and whatnot, that people find that and find it so young. So yeah, was there anything else that I guess experienced in that time, where in those years where you were getting rejection after rejection, that really you were thinking, this is the reason, this is my why, that I need to carry on and I need to have this happen?
Yeah, it's a really, really good question, because there was no question about it. I was going to continue trying and fighting, and I think the main thing that I can put it down to was
Mm.
just the sheer love of the job. And again, I don't take for granted at all that I'm in an incredibly fortunate position to genuinely love my job. I really, really do. But the fortunate thing as a therapist is the people that are coming to see you have already accepted that they've got a difficulty, and they've decided that they want to seek help. So actually, they've gone through a lot of the therapeutic process before they arrive at your door. So really, the therapist's job, arguably, in some cases, is the easy bit, because the hard bit is more often than not recognizing you've got a problem and seeking help. And so
Mm.
to then be there to offer skills and listening and to an ear to people's problems and possible solutions is just such a rewarding thing to do. And not least when you then see how people's lives, their relationships, their careers change as a result of the kind of therapeutic work that they have done. And that I haven't heard of that in any other career, really. It's such a wonderful thing to experience and to be party of, and a very personal part of someone's life that I have the privilege of being a part of.
Mm. One question on that I've always wanted to ask is, how hard is it to separate your job and when you, I guess, leave your practice and leave the room after having some of these extremely intense and conversations? How easy is it to leave that at the door?
It's a really good question. People ask it a lot, and there isn't a simple answer. I think that everybody's different in how they do this. I have always been someone that can compartmentalize areas of my life. When it's the weekend, and I'm not thinking about work. When I'm at work, I'm 100% in work, and I'm not thinking about what's going on at home or that evening or in the evening. I'm quite able to kind of switch off and to kind of just be quite present, I guess. And of course, there are times when that doesn't work out. But I'd say on the whole, that's one of my strengths that has really enabled me and to do this work. But of course, there are always
Mm.
times where you have very, very distressing conversations with clients, or they give you real reason to worry about them. Perhaps they maybe are so unwell that they could be of harm to themselves, and you're the responsible clinician, and you have to go home that night and just hope that they're going to be okay and that they can manage until you can call them the next morning or whenever it might be. And that is really hard for sure. It's not an easy task. Ways personally that I have found to cope with that is historically, I used to always run home from work. And that was a really nice
Mm.
segue between work and home, and a good kind of way to switch off, to change gear, to expend any kind of excess adrenaline or anxiety that's built up over the day, but also then to sort of enable me to start fresh as I walk in the front door or go on to whatever I'm doing in the evening. So exercise has been important, but the other thing is it's so key where you work and the setting you work. And I work part in NHS and part in private practice, and in both my clinics, I have supervision, and having someone that you can go to on a weekly basis or on an ad hoc basis where needed and say, I'm really worried about X, and as a means to offloading and processing my own emotions, but also as a means to ensuring that you've done everything you can in order to act responsibly and to keep the client safe. And so having that person always there that you can, speak to and offload to and make yourself accountable to is just really important part of the work.
I mean, it's definitely a skill. It's something I really struggle with, compartmentalizing my work and life. But going for a run is a really interesting, because I'm definitely guilty of getting home and then just letting that, and the weekend, and if I've had a bad day on Friday, letting that thread through to the weekend. But it's good that you've also got that supervisor there. One thing I know at the start of CBT therapy or therapy in general, they do ask you that if you it's is it that if you're experiencing suicidal thoughts or there's an element of that, that is that a rule that they are able to, because there is confidentiality normally, but is there a rule that if you believe that that person is of a harm to himself, that you can get in contact with someone?
Yeah, absolutely. So ultimately, as clinicians, we have a duty of care to the general public, whether that be the client themselves, whether that be others, or whether that be ourselves as a therapist. And so that presides over everything. So, what we tend to say to clients when we first meet with them is that everything we talk about will be confidential. However, there is a caveat to that, and that's if I'm concerned for your safety or the safety of someone else, I may be obligated to breach confidentiality and order to ensure safety. And what I tend to kind of say is that actually, what I'd ideally do is speak to you as the client about that first, and wouldn't do anything
Mm.
without keeping you in the loop. But there might be times when I couldn't get hold of you and I was really worried. And in that instance, I would have to act in accordance with the risk, and that may involve breaking confidentiality.
Yeah, thank you for sharing. Where I want to go to next is, what is CBT?
Yeah. So, cognitive behavioral therapy, or CBT as it's abbreviated to, is a type of therapy. The therapies world is a bit of a minefield. There are lots and lots of different types of therapies. They've got quite jargony names, and it can be really hard to know what's right for you if you're someone looking for therapy. CBT, short for cognitive behavioral therapy, currently, as it stands in the UK but also worldwide, is probably one of the most evidence based therapies for a whole variety of depression and anxiety disorders. So it's the most widely used. In terms of what it is, CBT tends to focus on the here and now. It looks at what are the current difficulties and areas of distress that someone is experiencing, and the way that we look at those areas of difficulties and make sense of them is by trying to break down problems or areas of distress into thoughts, feelings, behaviors, and physical sensations. And in doing so, what we are trying to understand are what are the thoughts, which is your cognitive bit, and what are the behaviors, which is your behavior bit of CBT, that are maintaining an individual's distress or their problems. So that's the major first step of CBT, is identifying the source of distress, and then trying to break it down into thoughts, feelings, behaviors, and physical sensations so that we can work out what is keeping that person distressed. Once we've done that in CBT, we take quite a solution focused approach. The idea is that if we can start to challenge unhelpful thoughts that an individual is having and to change behaviors that may be keeping the distress going, that the distress will start to get better and ease off. So, the whole theory behind CBT is that it is the way we think about a situation that in turn affects the way we feel. So, if we can challenge the way we think about situations, then we can change the way we will feel in response to them. And that in turn can affect the way we behave. Equally, if we can change the way we behave in reaction to situations, that also in turn will prevent us from reinforcing negative distress and hopefully make situations feel more manageable. Does that make sense?
That Yeah, that was incredibly explained. Yeah, thank you so much. And it really made me think back to the sessions that I've had, because I was basically just disasterizing certain situations in my head. I'd think something, and in my head I'd already be at the worst case situation, and nothing would have happened. I'd just been sitting there thinking. I could already feel my body tensing up. It like my thoughts would be running, and CBT did an amazing job of basically just creating a really good set of evidence of why that situation, why I actually don't have any evidence that that situation is going to happen, and why that even if that situation happened, that it wasn't going to be the end of the world, and that things that I could do to actually mitigate it happening in the first place, or even just coming to a terms of acceptance. And yeah, that was just an amazing explanation that kind of really put that together in my head of, because this happened a while ago. But yeah, thank you for sharing that. And why do you think CBT is effective?
Um, this is a really difficult question because we know the science tells us that CBT is one of the most effective approaches for a huge range of difficulties at present. But one has to bear in mind that yes, it is very effective, but it doesn't suit everyone, is the first thing to bear in mind. And also, the other thing to bear in mind is that a lot of other types of therapy, like, for example, psychodynamic psychotherapy or more integrative styles of counseling, are harder to measure. So,
Mm,
CBT, in part, why I think it's effective, but also why I think there's good evidence to support its effectiveness, is that it's concrete approach for lots of difficulties that we use CBT to treat, such as depression and different anxiety disorders like panic disorder or post traumatic stress disorder. There is manualized treatments. So we can follow quite a robust evidence based manual and trust that it will be quite effective if the client is able to get on board with it. So there's really good CBT treatments that are very specific to different difficulties. I think more broadly, though, as well, the reason that CBT is very effective is that we live in a really fast paced world where there's a lot of stress and pressure to achieve all the time. And CBT plays into that quite well because it's a goal focused, time limited approach. It's not a therapy that's intended to go on
mm,
and on and on. It's a therapy that's intended to be goal focused. You achieve your goals together in conjunction with your therapist, and the therapy ends. Yes, you might have some follow ups, but it's not never an open ended type of therapy. And it's not just about talking about the past. The past is important, it's really important. And some presenting difficulties, such as post traumatic stress disorder, we need to talk about the past. But more often than not, in other difficulties that you use CBT with, you don't need to talk or focus too much on the past. And people often quite like that. They want to come in, they want to understand and make sense of the
mm,
problem in a timely way, and they want to get their head down with the therapist and think collaboratively, how do we fix this? What needs to change? And CBT lends itself perfectly to that type of person that's seeking that sort of help. The other thing to say is that the CBT work doesn't really happen in the 50-minute session that where you're actually sitting with the therapist. We have obviously hundreds of hours between sessions if you're meeting with a therapist weekly where you've got to be practicing what you've learned. So that 50-minute to 60-minute session that you have of CBT a week is much more about planning for how are you going to cope in the other 168 hours of the week that you've got outside of this session. And again, people like that because you get value for money if you like. It's not just about what am I thinking, not
Yeah.
just about coming and kind of dumping all of your difficulties in the session and then walking out feeling a bit lighter. It's actually about how do we make things better, not right now in this moment, but also over the next week and coming weeks.
Yeah, and what could, I don't know if homework's the right word, but what would that work outside of the session look like? What can that look like? What are some of the exercises that you've done with people before?
Yeah, it's a good point. We use the term homework quite often in CBT, but people often don't like it. So we sort of choose carefully between session tasks, homework. It sounds a bit schooly, doesn't it? Some people are okay with it. But yeah, there is homework involved in CBT. It's not like you might think of in terms of school homework. More often than not, when you first start a course of CBT, there may be a bit of diary or filling out or form filling. And the idea is that the first stage of therapy is about trying to gather information about what's happening at the moment in order that you can put it under the microscope and break it down and make sense of it. So there may be a little bit of form filling at the beginning. There may be some questionnaires. There might be kind of keeping a mood diary where you write, for example, every couple of hours of your day, you might write what you've been doing in that time in brief and how you've been feeling so that further down the line in therapy, we can start to look at how is your mood fluctuating throughout your day, depending on how you're spending your time. But further down the line with CBT, if you're working on, for example, you explained earlier about having quite catastrophic thoughts where your brain was just going to the worst case scenario the whole time. And that's really, really normal. We see that all the time. We might set someone a task of actually, when they notice their brain doing that, is there something else they can do either to distract their brain or to, as you mentioned, challenge their thoughts? So that might be sitting down and writing out their thoughts and then looking at what's the evidence for this thought, what's the evidence against, and again, writing it down, and then thinking about what might be a more healthy or helpful way to think about this situation that's perhaps a little bit more reasonable and in proportion to the trigger. So that's the written side of things, but then there's a huge behavioral component to CBT homework, and this is probably where you're going to get the biggest shifts, which is actually what individuals could be doing differently. So for example, I might set a client, we might collaboratively set a task that they go and join a gym this week, or actually when they're feeling
Mm.
down, rather than going locking themselves in their bedroom, they try going and chatting to a housemate. So they could be quite kind of behavioral goals like that. If they've been avoiding situations, that's very common in lots of kind of mental health presentations that people avoid or they hide away. We might think about, is there one thing that you've been avoiding recently that you could try and do this week? And
Mm.
that might be the task. It could be as simple as paying a bill or ringing the gas company, to sort out a problem, but just trying to set kind of behavioral goals that help someone to feel like they're moving forward and challenging some of their unhelpful behaviors.
Yeah, so powerful. I think that is, yeah, I just think that was such a good passage explaining what CBT can look like and how powerful it can be. And yeah, it was almost making me like emotional thinking back to just how much it did change my life in that moment. And I've actually in kind of preparation for the conversation, I actually managed to find out or find the notepad of where I wrote down all my kind of CBT lines where it goes like, there is a possibility that this could happen, but even if that does happen, and then it's like all the evidence for that suggests, and it's
Fantastic.
I just think the way you explained it there was just yeah, really good. In terms of the word that I think comes up a lot in the mental health conversation, and I know this is an extremely broad term in a sense, and there's a lot behind it, but what is trauma?
Yeah. It comes up a lot. It's definitely a bit of a buzzword at the moment. I suppose when we're thinking about trauma, there's two ways to think about it. One is when we're thinking about it in a clinical and diagnostic sense, and one is more when we're using it linguistically to describe someone's experience. So if we go with the latter first, when we think of trauma as a therapist, what we are concerned with are what are the life experiences that our client who's sitting in front of us has been through that are having a negative impact on them now. And that could be as smaller things as a memory of coming home from work one day and getting a B rather than A, and dad saying, "Why wasn't it an A?" To as
Mm.
bigger things of, coming home from work and seeing dad beating mum up. Excuse the sensitive examples, but the extremes are such. So, trauma, really, broadly speaking, is somebody's negative past experiences that currently impact them now, whether it be in terms of causing distress or impairing functioning and impairing their ability to get on with life or to live life in the way that they would like to be. If you think about trauma more from a kind of diagnostic and clinical sense, so often, we talk about that diagnosis, post-traumatic stress disorder. To diagnose post-traumatic stress disorder, there's slightly more specific criteria about what we classify as a trauma. On it doesn't mean in some cases that it will have any more or less of an impact on an individual. It very much depends on individual differences. But when we're thinking about PTSD, we're thinking a little bit more about traumatic experiences where that someone witnesses or is a victim of a near death situation or a
Mm.
sexual assault or a sudden death or loss. So we're thinking about perhaps what one might see as the more life threatening type events, such as a car crash, a rape, witnessing someone dying in front of you for whatever reason that's unexpected. Those types of traumas, more from a clinical perspective, would qualify someone to potentially, depending on how they've reacted to that trauma, qualify for a diagnosis of PTSD.
And why is it so important to address trauma?
It's really important to address trauma. I mean, the first thing to say is that everybody experiences trauma in life, whether it be those really big traumas that I've explained would kind of might classify someone,
Mm.
or indicate possible PTSD, or whether it's the more everyday traumas. Everybody experiences trauma everybody experiences it in life, and more than 70% of people in life will experience one of those big traumas, those really significant near death ones. So trauma is very, very common, and the majority of people, we're talking 90% ish, will recover from trauma spontaneously without needing it addressed. But you've got a significant minority that won't spontaneously recover from trauma, and therefore, it is very important and often a source of lots of people's distress. So the research has been a little bit slow to catch up in terms of kind of analysing and the links between trauma and current presenting difficulties. But what we know now is that trauma is often the kind of risk factor that leads to someone experiencing depression, PTSD, anxiety disorders, psychosis. So in my NHS job, I work with clients who have psychosis. More often than not, they hear voices that feel like they're coming from somebody who is actually there, but in fact, there isn't anybody there. And when you analyze the content of those voices, more often than not, they parallel voices of past traumatic abusers. So we know that a lot of people that present with mental health difficulties will have past traumas that very directly link to the current distress they're experiencing. We also know that if someone meets criteria for PTSD, which won't be everyone, but will be a significant minority, that it's very difficult to just recover on its own without treatment. So we need to address traumas memories, because if we don't, you don't give your client the best chance of recovery. You could do some really lovely work on improving their mood if they present with depression, or improving their self esteem if that's their main issue, or their anxiety, or their flashbacks and their nightmares. But ultimately, if you do not get to the root of where these difficulties are coming from and help an individual to process, make sense, and then later rest these difficult memories, you've only really done half the work. And it's a bit like sticking a plaster over something and not really healing the wound from underneath. So addressing trauma is really important. It's much more on clinicians' radar now than it ever has been, which I'm really, really pleased about. But it's also still quite, people kind of have anxiety about treating it and going there, because there's that kind of idea that you might open a can of worms and not be able to kind of close
Mm.
it. And we need to get over that fear, because actually that's not the case. If you get that stuff out, you organize it in a safe place with a qualified clinician who knows what they're doing, then there's real potential for relief, respite, a reduction in distress, and also to no longer feel stuck and like you're living in the past, which so many people will say that they do.
Mm. And I've got a question after that. So, for family members or people that have a loved one going through, I know people that have had PTSD and have experienced or are experiencing psychosis. Is there any advice on how to show up for that person? I guess they're two very different. If we just go with PTSD,
Mhm.
for someone experiencing uh, real distress and experiencing and recovering from trauma,
Yeah.
ho- what's a good way of showing up for that person during that period?
Yeah, it's a really important question. I think you're right to kind of separate the two, because it would be a slightly different approach. It sounds a weird thing to say, but the wonderful thing about if someone's treating PTSD or presenting with PTSD is that there is incredibly effective treatments out there for PTSD. It's almost one of the most treatable mental health problems that there are currently. And therefore, whilst people find it a little bit odd to hear, I'll sometimes say to people the really good thing about now us knowing what this is that we can help. And I really, really mean that. The recovery rates are high with PTSD and the treatments are very, very effective. In terms of how you, as a family or friend of someone, might show up for someone who's experiencing PTSD, people with PTSD have more often than not in living in a constant state of fear. And the reason is because their brain has got a little bit muddled, and the fear component that is housed in the amygdala of our brain, it is basically being activated at times when there isn't actually a threat. So if you think about a fire alarm going off when you've burnt your toast, there's not actually a fire, but the fire alarm has picked up danger and it's going off. Someone with a PTSD, suffering from PTSD, that's what's going on in their brain. They're perceiving any minor threat as very, very dangerous, potentially life threatening. The alarm system in their body is going off, and they're going into a chronic state of anxiety, which is very difficult to come down from. So they need to be made to feel safe. Best thing that we can do as people around individuals who are experiencing PTSD is to do what we can to be kind, to be compassionate, to be forgiving, and to make them feel safe in whatever way that person needs. And that will vary on person to person. So I appreciate that that's a slightly broad
Mm.
answer. And to encourage them to get
No,
help, really, because the help is there and it's incredibly effective.
No, I think that was a really good insight into, I guess, what might be happening in their brain, and because if you are currently not experiencing that, then it can be easy to, I guess, underestimate how much of an impact the surrounding world and all the stresses of life can have on someone experiencing
Yeah.
that. So that was really good to kind of, one thing that you said before, which I kind of want to dive into. And I don't know, I can't remember the exact wording, but around your work with people experiencing
Mm.
psychosis, that the thoughts they were hearing were parallel to previous abuses. Can you speak a bit more about that, if there is any more information on it?
Yeah, absolutely. So we know that something like as much as, if not even more, 90% of people that have had an experience of psychosis will have experienced fairly severe trauma in their life. It may even be up to 100%. The evidence is still emerging, but we know the numbers are high. And more often than not, those traumas are interpersonal traumas. So, what we mean by that is physical or emotional or sexual abuse. It's often from a family member, although not always, or neglect. Traumas that involve other people, basically, rather than kind of natural disasters, tsunamis, or accidental events like car accidents. And people with psychosis typically will experience a combination of positive symptoms and negative symptoms. So when we think of positive symptoms, we're thinking about symptoms that wouldn't typically be there in the general population, but people with psychosis might experience. So that could be hallucination. An example of a hallucination would be hearing a voice that you truly believe is there, but that no one else can objectively hear or see and knows isn't there. It could be seeing a person in your room that, again, you see as completely there and real, but your partner lying next to you can vouch is definitely not there in the room, and anyone else in that room could say that there's no one there too. So, and the other positive symptom that commonly people experience is delusion. So more typically, one might be familiar with kind of paranoid thoughts. So we often work with clients who, for example, maybe believe that their flat's been bugged and that the MI5 are watching them,
Mm.
for example. And in fact, there's no evidence to suggest that. And it seems quite illogical, relevant to the client's situation, but they are absolutely convinced. And then the negative symptoms of psychosis are more symptoms that anyone in the general population could experience. And we all experience to a degree on a spectrum. So things like low mood, sleep difficulties, lack of motivation, energy, etc. What we know in terms of where the literature is at with the links with trauma and psychosis is that if you were to put under a microscope people's positive symptoms of psychosis, so those hallucinatory experiences or those delusional ideas, often, not always, but often, when you then explore the life experiences that that individual has had, there are common themes which would perhaps provide some form of explanation as to why that person is hearing those particular voices, for example, or seeing those particularly scary looking figures, or believing perhaps that someone is targeting them, or that they are at risk or harm. And it's exciting that we now know this. This is an area that I guess it's been a bit slow to develop in the field, because now that we have this, the evidence suggests, and nice guidance, which is our kind of Bible for what sort of treatment we should offer, tells us that where you are working with someone therapeutically with psychosis, we must address the PTSD if it is there. Because if you address the PTSD, and it comes back to your question of why it's important to address trauma, then you may get some let up on the positive symptoms of psychosis. And again, that I guess that the effectiveness of that is still being kind of assessed and researched and evaluated, but there's a strong hypothesis to suggest that that will be really effective for people with psychosis in terms of their recovery.
That is fascinating. The brain is completely fascinating. That a trauma like that can then lead on to some of those like real physical symptoms and the delusion or paranoid thoughts, which kind of rings true to the experience that I've had with someone that's going through it. Yeah, I mean, it's just incredible that people are dedicating their lives to studying this so that those people can get the treatments that they need and that they can keep improving and help to recover.
Yeah, definitely.
One on the subject of, I guess, the the
Mhm.
podcast, are there any particular themes that you've seen? Because I know it's always weird to talk about difference between genders as such, but are there any themes that come up in men more often, just out of interest?
Yeah, it's really important to actually acknowledge the differences between gender, because mental health, and in terms of how it presents it to services and clinicians, looks quite different for men and women. For example, people's journeys to therapy have often been quite different depending on your gender. In my experience, and from my research, my doctoral research looked at some of the barriers to mental health help seeking from veterans, so any ex-military personnel, of which all of my client group were men. And so this is of particular interest to me. And some of the things I guess that I've observed and learned through doing the research is that actually, I think whilst stigma has got a lot better in our culture, and openness to talk about mental health difficulties and seek help where necessary is far more accepted, I think we do still have long way to go in terms of breaking down these barriers further. I think quite often with men, they may live in silence with difficulties for longer than women before they perhaps even A, recognize there's a problem for themselves, and then B, talk about it. So I think that's a theme. I think one of the reasons for that is that, again, this is very much generalizing, but on the whole, I think men have a lot more self stigma, so much more kind of shame and criticism towards themselves, and perhaps feelings of failure for accepting and owning the fact that maybe they're struggling. And I think men also experience anticipated public stigma. So worrying about what other people may think and predicting that it's going to be quite negative if they are open and share that they're having mental health difficulties. And that leads to big problems, because if you're not talking about the difficulties, even if you don't see them as difficult, but if you're not talking and sharing about your experiences, you're not allowing yourself as a male the opportunity for someone else to shed light on the fact that maybe what you're experiencing is not okay, it's not normal, it could be helped. You're also not allowing yourself the opportunity to learn from others around you, friends, family, colleagues, professionals, whoever it might be, that actually maybe there is a solution and help out there, and where therefore to go and get it. So I think yes, it is a generalization, but in men, recognizing there's a problem is there's still work to be done there. I think having recognized and accepted that there's a problem, actually seeking help and trying to kind of overcome some of that self and anticipated public stigma in order to do that is still a challenge for men. And I also wonder whether the stiff upper lip culture that's been so prevalent for so many years in the UK for men has led to men feeling quite kind of undeserving of help relative to women and children, for example, or older adults. So I think there are gender differences still that remain. I do think it's important. I think there are themes across men. It's really important that we work hard with the population to try and overcome some of these issues, as you are doing with your amazing podcast, because we know that the risk of suicide in men is just so high. And more often than not, those men will not have sought help. And that's such a shame, when suicide is such a preventable difficulty. What underlies suicide is lots of kind of emotional distress that we can treat using a combination of therapy and medications and other support. And so it's really, really important that we continue to work to break down those barriers for men around noticing when they're having difficulties and seeking help in accordance, so that we can try and reduce the amount of preventable suicides that there currently are, because it's a great shame that we're losing lots of great people as a result of this.
Yeah, so thank you so much for articulating that, and I guess bringing your experience and the research into it. What do you think are some steps to get men, I guess, reduce the stigma of men speaking up and being emotional? Is there any initiatives you've seen, or any ways that you've worked with clients on the CBT side to get them to open up to close ones about their mental health and how they're really feeling?
Yeah, so I think there are lots of things being done, some perhaps better than others, on public levels. So there's lots of stigma campaigns that are occurring, for example, and lots of kind of targeted charitable groups that are trying to kind of increase awareness and acceptance around men's mental health. I think on an individual level, in terms of what we can do as therapists and what family and friends around men can do, I think on a day-to-day level, we all, as members of the general population, have a responsibility as men and women to be challenging ourselves to talk more about our mental health difficulties, and to face that fear that may come with that, in the knowledge that it not only might help us, but it will help others, and it will contribute to a shift in culture where it's more accepted and normalized to talk about these difficulties and to take ownership of them, because it's ultimately that's going to enable help and recovery, which is so important. In terms of the therapist, yes, so I often work with men in my work, and it will often come up in sessions about who they maybe have shared their difficulties with. Some are very, very open, and that's lovely to hear. Others aren't, and there is a lot of shame about sharing difficulties. Perhaps some anticipated kind of stigma from others. What if they don't want to be my mate anymore? They lose respect for me. They don't want to hang out. They see me as a bit risky or vulnerable or unpredictable. So lots of kind of shame-based predictions that lead to people not wanting to share their difficulties. So much like we would in CBT for any difficulty we're working with, we look at challenging some of those thoughts by looking at the evidence for and against them. We might do some surveys to find out what other people's experiences are. And then we want to change the behaviors. So let's try this in a way that feels safe. Is there one safe person that you could speak to? That might be a homework task this week about some of the difficulties you're having. Let's just try it really gently, see how it goes. And I will say to clients, listen, if they throw it back in your face and you get an awful reaction, I'm not going to ask you to do it again. But I think it's worth a shot so that we just choose one person that you can predict is relatively safe to go and share these difficulties with. And we'll start from there and we'll build up. And as you might imagine, more often than not, how it's received is never as bad as we might predict. And in fact, is often very, very positive and reassuring.
Thank you. I remember hearing when I was going through my journey with CBT and why I wanted to start this podcast, and what you were just saying there, it all resonated so much. And I heard the quote was like something like, there's a lot of men living quiet lives of desperation, I think was the quote. And I remember it was a good period of like years where internally I was having like extreme distress. Like I was really anxious, and at points having really quite intrusive thoughts that I didn't want to have or didn't know how to process. But there'd be so many times where I'd walk into a room or with a group of mates, and I'd have all these things going on in my mind that had been racing for ages, and I'd ask, "Oh, like, how are you?" So, yeah, I'm all right, mate. I'm good. I didn't feel. The genuine feeling was I didn't think anyone would care. That was the that was the honest feeling. I didn't think anyone would care, or that I didn't want to burden people. And having gone through that and had CBT, which genuinely 100% changed my life for the better, I just want to do this podcast to help people realize that they're one people do care, and your feelings are valid, and that seeking help for like really distressing thoughts and situations and things you've experienced you should never have a stigma attached to it. Happiness and having good mental health should be seen as like such a strength. So yeah, just thank you so much for coming on, because that was one of the most articulate, I guess, yeah, just the way you articulate yourself and your thoughts is incredible. It's like a real mastery to do, and you're clearly so passionate about everything that you speak about. So yeah, thank you for coming on, Harriet.
My pleasure, Nick. Thank you so much. It's really great work that you're doing. It's lovely to see that this is happening. It's really important stuff. And I've just echoed that message that you've said of just please, to any listeners, don't suffer in silence. Seek some help, GP or Samaritans, 116 123, free phone number, or a family member or friend, but just do not suffer in silence. It's the worst thing that you can do for yourself.
Thank you.